Thanks for everyone coming out here on a Wednesday afternoon, 1 o'clock your time, 4 o'clock my time. And my name is Gioia. I'm a pediatric neuropsychologist. I'm here at Children's National Health System and the chief of the Division of Pediatric Neuropsychology. I've been here at Children's now for 17 years, was in Baltimore for 13 years before that, Boston before that, all over the place. Anyways, I'm on faculty at GW Medical School. We started, I've been working in the brain injury field really since I finished my fellowship back in the 80s. And as with most of us in this field, we started out working with kids that had more severe traumatic brain injuries. And then what we've learned as the science and neuroscience has developed is the effects of injuries across the full spectrum, mild, moderate, and severe, which frankly are very inadequate ways to describe this complex injury. But and so since 2003, we've had a focus here at Children's National on concussion or mild traumatic brain injury, and both in a clinical way, we have a variety of clinics around the area. A research way, we've been doing various kinds of research studies and publishing on that over the years. We train folks to become concussion specialists, and then also do a fair amount of community, both education and advocacy on more of a public health level. And I've worked actually with the CDC since 2003 on various projects, including the Heads Up toolkits and all. So anyway, so it's been an interesting journey along the way. What we know now versus what we knew in 2003 is dramatically different. Most of it good. Some of it you'll maybe hear me bemoan a little bit, but we still need to know a lot more, especially as it relates to kids and the effect of this injury across the developmental spectrum. My basic training is actually as a developmentalist, and so look at everything in terms of how development is affected by a variety of conditions. So that's kind of me. Just a disclosure, one of the things that I do is to develop tests and measures, particularly in areas where we don't have them. Some of those things I receive royalties for, others I don't. So what we're going to do today is first start off just to make sure we're all kind of on ground zero together around concussion basics. I'm not going to spend a lot of time on that, but I want to make sure that we're generally understanding what this concussion, mild traumatic brain injury entity is. Then we're going to talk about concussion complexities. As it turns out, most kids that recover in what we call a typical fashion, and I'll go into that in a little bit, many of us don't even see. It's oftentimes the more complex cases. But I'm going to talk about how we understand these injuries, how we really treat both the less complex and the more complex kinds of injuries, and I'll be weaving different kinds of case stories kind of throughout the talk here. And then sort of as we're doing that, we're going to talk about how we assess the symptom patterns and profiles and how we treat this. So it's kind of a little bit of a soup to nuts piece here, but again, I'm open to questions that you may pose as we go along the way. Just to put a shout out, there is a paper that was published last year based on this report that was actually put out a few years prior, and that paper is in JAMA Pediatrics, and it really is a review up until about 2015 or so of the literature on the diagnosis and treatment of mild traumatic brain injury in children, cutting across all different kinds of etiologies, with recommendations for the various kinds of things we can do to help out children and families and schools and practitioners with this. There also have been a number of sport-related meetings over the years and publications most recently, now almost 3 years ago, in Berlin, where we pediatric people get together and really look at the issues that we need to understand and advocate for as it relates to kids. And again, a lot of what we see in the sport world really relates to the rest of the injury itself. But this paper is one that, talked about a variety of things, such as that kids may take up to 4 weeks to recover, and that's not necessarily so unusual. And that this whole idea of going out and baseline testing everybody on the planet is neither practical nor probably even necessary to ultimately manage the injury, although it may be important in some cases. And that we really are changing our treatment now to a much more active and progressive model. And the best thing from my perspective is that we have been talking now more explicitly about what we do in schools. Just a little bit of a background too, for you, those of you who don't know my background. I actually trained initially late 70s to mid 80s at the University of North Carolina, Chapel Hill, in school psychology. And my first job, the first 2 years, was as a school psychologist in Maryland, and then went on and did my fellowship training for the next years in Boston in pediatric neuropsychology. But my heart has always been in the schools, and so much of what we see, even in the hospital setting here, in working with kids with all kinds of neurologic complexities, I mean, not just brain injury, but tumors and epilepsy and cardiac disease and lots of things that affect brain. Virtually every parent that comes in is worried about how their youngster is going to do in school. And so that background is just tremendously helpful. And I'm still a card-carrying member of NASP and think that what happens in schools, my understanding is we have some school psychologists on the call here, is just so valuable and important and irreplaceable. So, and so we got the school issue into the sport people, which I will tell you that 10 years ago, 12 years ago, they didn't know what the heck we were talking about when we were talking about schools. So it's good to see we've evolved. So again, I'm going to weave different kinds of typical and atypical kinds of cases in here, talk about the various factors and ways that the atypical presentation can occur, family kinds of issues, and then what we do to manage it, which is not to use that 4-letter word of rest, as I say there. So let's talk first about the basics. What we know is that a concussion occurs when there's been a blow or a force of some type to the head or to the body that causes that brain to move back and forth. And you can think about that as almost like, whiplash kind of thing. What it does is it causes a stretching, straining, change in both the chemical and the electrical properties of the brain, which affects, of course, then how the brain works. And we see that as manifested in the various kinds of signs and symptoms. And once these changes occur, that brain is in a pretty vulnerable state, and we have to make sure that it is not subject to any further injury or even stress. And I'm going to talk a little bit more about that when we talk about the kinds of ways that we need to manage this injury. Well, we also know, for those of you who are involved in the TBI field, you know this already, but the vast majority of kids, probably 90+%, are actually in the mild, quote unquote, TBI world. They don't go to the hospital. They don't, need rehabilitation in the more classic sense. But nevertheless, they do need assistance. And we work very hard with our emergency departments and our pediatricians, our urgent care places, to really identify and manage these. But we also know there's a fair number of kids that are walking around that have not been identified, and that's not a good thing. Of course, there's many different causes in our sports crazed society. Everybody thinks about sport concussion and football and all that kind of thing. But the reality is that's only a portion of the injuries. They occur many other ways, as you can see on the list here. And frankly, the brain doesn't differentiate whether it's a linebacker that hit it or whether it hit the pavement. The one thing I will say that is unique to the sports world is it is a programmed return back to that risk situation. And so we do need to put special kinds of rules and protections in for kids as it relates to that. You know, I'm going to use various terms, you know, concussion sometimes, TBI sometimes, traumatic brain injury sometimes. Probably try to stay away from mild, which is a silly term, frankly. And it's, you know, as I tell people, mild, moderate, and severe are just terms that are relative to each other. When you have this injury that is, you know, framed as a mild traumatic brain injury or concussion, it doesn't feel mild when you're going through it. So a little bit of an insulting term, you know, for the individuals going through it. But just FYI, I'd probably use TBI or concussion as we go about it. We also know now more about this kind of underpinning of the problem. When the brain is stretched and strained, we know that generally speaking, this doesn't result in a tearing of the tissue, certainly not at a macro level. But it does, with that stretching and straining, affect cell wall integrity, and various kinds of chemicals go in and out of the cell at inappropriate rates. And this is just a slide that my good friend Chris Giza put together now 18 years ago. He's updated it since then, but it's basically remained where we see that the white horizontal line, if you follow my cursor here, is kind of the norm, and everything that falls off it, like the potassium, the calcium, glucose utilization, cerebral blood flow, is now rendered abnormal by that blow, and disrupts then that cellular function and the metabolism of that brain. What you see is that over time, these things begin to return back to their norm along the way. But during that time, you have this real sort of energy crisis and you know, neurologic challenge. Our good friends at Wake Forest have looked at this as biomechanical engineers and as neuroimaging people, and have put together a couple of models here to show the kinds of stretches and straining that occurs when the brain takes that force. Now, let me just say that most forces or hits that we take to the head do not result in any kind of impairment, you know, to brain function. You know, we were built to take at least a mild to moderate hit. But we know that you can exceed a certain threshold, and that stretching and straining can then again disrupt the integrity of the cell wall, disrupts the axon, which is of course the electrical cord in the brain that is so complex, and it disrupts then that neurotransmission. And we talk about this injury as being one that is really a software injury of the brain. So it's the stress and strain of force on the cell wall, on the axons, diffusely, changes concentrations of these different chemicals. And what this does is it results in a real mismatch, you know, between the metabolic needs of the brain, activity, produces this energy crisis, and basically the brain is not able to function in that same complex, you know, sort of computerized type of way that we normally see it occur. And what we see just from a general timeline of these things is when the injury is taken, you know, rarely, or I should say infrequently, do we see a loss of consciousness. Again, we think it's about 10% or less of the time. When it does occur, it's usually a matter of seconds, maybe to a few minutes. But what does get disrupted, at least at a higher rate, though certainly not universal, is the ability of the brain to kind of process information in memory and hold on to it. So we have disruption of information that occurred just before the injury, called retrograde amnesia, and information that is, you know, being presented to the individual after the injury. They will say things like, I really don't remember what happened, you know, for that 5 or 10 minutes prior to the injury, or, you know, I don't remember until 20 minutes after, you know, the injury happened. So, and we know that this produces a set of cognitive and sets of symptoms we'll talk about in a minute, balance problems, a variety of kind of challenges to the individual. And then very importantly is we're going to talk about what you come into this injury with can modify the way that it plays out, you know, particularly in the cognitive and the symptom-based ways. And we'll talk about more about that as we talk about different kinds of cases that come along. But this is a sort of a timeline that I like to put out there to sort of give you the viewpoint. And you know, between the amnesias here, from the retro to anterograde, these are things that are more of that acute stage. And then hours to days to weeks later, we start to see some of those other kinds of cognitive and symptom-based and balance-based issues. So injury characteristics, basically we want to assess symptoms, and we want to know what are those risk factors for the possibility of prolonged recovery. These three elements, A, B, and C, are the things that we built into the acute concussion evaluation, or the ACE, that we developed a number of years ago. And of course, when the software goes bad in the computer, it doesn't work real well. And so when the brain is disrupted in its functional capabilities, we observe some changes in the individual, whether it's cognitively, dazed, stunned, slow in responding, having troubles remembering what's being said, or various kinds of physical kinds of ways of manifesting this, you know, or behavior and emotion ways. We see that certainly in that sign kind of way, what you observe. And then we see the various symptoms that fall into these four categories: the physical, cognitive, emotional, and sleep. And so this collection of symptoms, obviously, if you just picked any two or three and you went through the day with blurry vision and trouble falling asleep and difficulty remembering, that would be a tough day. But what we know is that there's various constellations, you know, irritability with fatigue, with, you know, drowsiness and headache, you know, those kinds of constellations that happen, and that makes it tough for a person to get through their day. And we also have to remember that this injury, just like any injury, brain or not, can have psychosocial effects on the individual. Now, in this case, the unique thing about a concussion, there's no bandage, there's no cast, there's nothing that tells people that you're not doing well. And so it's often not appreciated. People are walking around, the expectations are you should be able to do everything. And that can really present some real stresses and challenges for the individual. When we're managing kids, we oftentimes try to help, you know, to kind of manage, and at least initially we restrict what they're doing, either because it's too much of an energy demand on them, or because maybe it's a risk for re-injury. And so they're cut off from their social group. And of course, with adolescents, that's a tough thing. You're taking their lifeline away. For some who do various kinds of, whether it's sports, whether it's theater, whether you're a really great student, you know, or a really close friend, and you're cut off from that identity, and that can be really difficult. To not be identified as you know, my go-to person, or that person that we rely on to win the games, or, you know, whatever your identity might be. And of course, none of us like to be thrown out of our element, and so we want to be normal. We want to return back. We want to contribute in the ways that we normally do, and to not do that obviously adds stress. And of course, that evil schoolwork. And so, you know, the amount of work that is starting to pile up, or the amount of work that you're not able to do as quickly, or that you just don't understand as well right now because of all these challenges that are going on. So these kinds of things pile on top of the injury in its more direct manifestation. So then the question is, like, what's a typical recovery here? And what we found through this study that was done in Canada and published in 2016, I was one of the co-investigators, was that, you know, we oftentimes hear, well, it'll take about 7 to 10 days to recover. Well, that's silly. In fact, I've always found that to be silly. That's with elite athletes, typically, you know, collegiate, sometimes high school athletes. But the reality is that when we looked at a very large sample of children and adolescents, the over 3,000 kids from 5 to 18, 70% were recovered within 4 weeks, but 30% weren't. And if you were an adolescent and you were a girl and you had a history of migraines and you had certain kinds of clinical findings, your recovery tended to be longer. So younger children did not have the worst outcomes. It was the adolescents in this sample that showed that. And that's our experience clinically as well. So age, whether you're a boy or girl, and also the injury type and severity all seem to play roles in how we manifest this injury and how long it takes us to recover from it. So, the big question always, whether you're a school nurse, a school psychologist, a teacher, a pediatrician, a mom or a dad, what are we going to need to do to help this person get better? Who needs treatment, and what kind of treatment do they need, and for how long, and what type is it, and when do we start it? And these are still questions that kind of remain out there, although they're being actively pursued. Again, we know the typical recovery case is within about 4 weeks, and we actually have some fairly basic things that we can do to help them recover. We also know that, again, maybe about 25 to 30% of the sample of kids that are injured take longer than a month. And that's not a small deal. That's at least 10% of your school year. And that can be a real issue here. So what we really are working on is, can we have a clinically predictive way of knowing, of assessing you and saying, you may take longer to recover, therefore we're going to do certain things to help you get better. Whereas you may not take so long, we're still going to help you with your recovery, but the complexity will not be quite as challenging. So the whole issue of how we target our treatment and rehabilitation is really an important area that people are studying now. And again, as we look at general symptom recovery, if we look at this, most kids are recovering by 28 days in the typical kind of way. And again, it shows us that really important that parent, healthcare provider, school all play a good contributory role to assist in that recovery. We also have kids here now. This red line relative to the blue line shows us that I'm falling outside of that typical recovery trajectory. So here, if you look at those green dotted lines, these green dotted lines are kind of that band of normal. Anything below this top line below would be considered within the typical range, and then the red falls out there. And so that's when we start to see complexity. And I can tell you that as we're going to talk, when you get to these complex cases, there are multiple factors that have to be considered. It's oftentimes not simply the concussion alone. As I mentioned earlier, there are the modifiers that play a role in here. I'm going to move on to concussion complexity, but let me just see if there are any questions that anybody might have before I move forward. You can put it in that little chat box if you like, and we can respond. Maybe just a second, because okay. Are there any questions about what we've just talked about?
Hey, Jerry, it's Amanda. Looks like we've got one from Sarah Magnano.
Okay.
You may be getting to this, but how do you measure the trajectory of their recovery?
Okay, good. Yeah, so the question is, how do you know whether it's the red line, the blue line in all of this? And that's a good question. So when the injury is identified, and actually I'm going to show some of the assessment measures in a minute. We built the acute concussion evaluation. Basically, it was published by the CDC back in 2007. It was because we realized that practitioners really didn't have a way of standardly evaluating kids to diagnose them. But then what you'll see is some of the other symptom scales that we've developed that really track recovery over time. And the bottom line is, this is still a diagnosis of a clinical nature. None of the imaging methods help us out in that regard. Again, as I say, this is a software injury of the brain, not a hardware injury of the brain. And whether it's CT or whether it's MRI of any type, they're really built for the hardware injuries, not the software injuries. So we really go by what the report of those symptoms are. And again, we plot that over time, and we can begin to see what is that trajectory of recovery. And I'm going to go through a little bit more of that here in a minute. Other questions?
Doesn't
No? Okay.
anymore.
Oh, sorry. Go ahead,
Can say
Amanda.
it doesn't look like we have any more right now.
Okay, thanks. So when we get to this question then, of sort of the complexity of it all, we look at, there are certain culprits that seem to play a major role. Kids with chronic headaches, kids who are just fatigued and wiped out for a long period of time, kids whose vestibular system, that balance system, that system that basically keeps us up, as well as our eye movements affect us, the dizziness, the balance, those kinds of issues, cognitive problems. The kids that say, I'm just really struggling with my attention or my ability to kind of hang on to information in my memory, our speed of doing things. And then the anxiety and the mood problems. These are the kinds of things that oftentimes are, we call the subtypes or the culprits for prolonged recovery. And so what we do is, again, the injury takes place. It results in these complex cases, some combination of these kinds of effects here. And really it's up to the clinician to define that by doing good standardized symptom assessments. Very important. But what we also know, and I put this blue sort of circle around it, is that there are other factors that play into this. For example, I'm treating a youngster right now who has a history of 3 prior concussions, one of which was last year, took about 3 months to recover. The other one was 2 years prior to that, took about a week to recover, and the other one was a week before that, took about a week to recover. So you have 1 week, 3 months, each one separated by matters of a year or more. This time, the injury occurs, and the question is it going to be a short recovery or a long recovery? And we don't actually have an easy way of predicting that. But what we do look at is the type of force that was taken. We look at the early symptom burden. We do know that the more your symptoms early on, the more highly symptomatic you are, the more likely it's going to take you longer to recover, the more involvement of the neurologic system it will take you. We saw a youngster yesterday in clinic who actually had a history of 2 prior concussions and had a weird sort of bumped her head kind of badly as she was trying to get into the car, and headaches started. But with and they then resolved, mostly in the next day with a mild level of a headache. When she came into clinic here, we had to do a few things and we kind of accelerated a little bit. But she had a very, small number of symptoms that were pretty low in their intensity. And that's the kind of injury you'd say is probably going to, resolve fairly quickly. Now, of course, she wanted to play in a field hockey tournament this weekend, as well as go diving and do a bunch of other things. And so we had to put a little bit of the clamps on those kinds of, vulnerable activities. But being able to assess her and monitor her and look at not only the types of symptoms, but the severity, the overall burden of them helps us to do a little bit of guiding in that recovery. And we also know, it's a little bit of a busy slide, but kind of walk you through it. Again, the typical recovery is in essence that green triangle that goes out to about 4 weeks, as I mentioned. 70+% of the kids recover within that time frame. We know, though, that there is a type of kid that really has these lingering, more prolonged headaches. So what do we do for that? Well, we do a lot of environmental management with these kids. make sure you're getting good sleep. Make sure you're doing a little bit of physical activity to start to get the heart rate up and going. Make sure that you're managing any stress. And again, we talk about, school. And then during the day, how do you take your day in doses so you're not wiping yourself out by 11 o'clock in the morning, but you're doing some activities, you're taking a little bit of downtime, you take a little bit more activity, doing a little bit of downtime. So for those kids that have the more persisting headaches that are affecting it, we really put in a much more active and managed day for them. But we also know that some kids have an atypical emotional response. They're really much more anxious. Their mood is really off. And so for those kids, we may need to really bring them into our behavioral medicine service. We do the same thing we would do with somebody that didn't have a concussion that was presenting, say, with a mood or anxiety problem. But it's really important that they get in right away and really help to frame, what's going on with themselves and feel a little bit more in control of their injury. And then again, the kids that have the difficulties with their attention and their working memory and challenges kind of getting their work done in the typical amount of time, then we really work really closely with the schools and look at how we can modify the curriculum, either reducing the workload, allowing them more time to get the work done, but sometimes even spreading it out where, exams are coming up, but we're going to push these out a few weeks and see what your response is. So various things that involve kind of managing the youngsters' cognitive demands. Other times we actually do more direct treatment where kids are getting, learning cognitive strategies and ways to really hold on to information, to put it into memory much more effectively. And then again, when we get the kids with the vestibular or the ocular motor where their vision's blurry, or again, vestibular where they're dizzy and their balance is off, we get them to PT right away, usually within a matter of, after the first, 10 to 14 days, and really get them actively involved in a rehabilitation program. So and then of course, many kids present with multiple elements here, and you've got to put in some treatments that cover both those things. So the idea here is really to sort of target what that subtype is through our assessments here. So as I say, symptom targeted treatments based on how we've identified that particular subtype as it comes along. And there are some physical exams to look at vestibular, to look at the ocular motor kinds of problems. There are cognitive tests we can do to understand the cognitive difficulties. There's not a test per se for headaches, but certainly the reporting of the youngster is important, as well as their sleep schedule and the extent to which they're affected. And you'll notice I have in parentheses down at the bottom of the bucket there, cervical. And we know that a number of kids have a real strain, with their neck muscles, and that can really exacerbate headaches by radiating up and sort of sensory sensitivities that affect their functioning. And so when we have somebody that's had a whiplash injury or something where the neck has really been torqued, we make sure that they go to PT and really work on that whole musculoskeletal system to address that issue. So again, we've got a bunch of clinical tools now at our disposal that we had not had 15, 20 years ago, but we now do. So I mentioned before there's the acute concussion evaluation, and this is something we developed again more so for the emergency room or the medical provider who sees the youngster within a matter of a day or two. Now you can use the ACE out, kind of going out, a week or two, but the point is it was built for really that acute phase. What we then built, again, this is all with our CDC funding, is something called the Post-Concussion Symptom Inventory. I'll go a little bit more into this in a minute, but it's split up into those 4 symptom categories of physical, cognitive, sleep, and emotional symptoms. So you can begin to look at, again, those subtyping areas that may be recovering just fine, or 1 or 2 of them may be having some challenges. And then we certainly see that the executive functions in these kids have been thrown off, and in particular their working memory, how well they can hold on to things, in active memory, their ability to complete tasks in an effective way or to initiate tasks, as well as then their control of their emotions. So when, again, I throw these out there because some of you may actually do some of these kinds of assessments in schools or in the community, and you want to kind of have these tools at your access. So one of the things, of course, to take into account here is that depending on the age of the child, they're going to understand symptoms, differently. So, a 15-year-old girl and let's say a 6-year-old girl are going to understand these terms and these symptoms, symptom experience a little bit differently. We might ask a girl who's 16, tell us about your kind of how you're feeling mentally. Do you feel a little bit foggy, fuzzy, a little unclear in your thinking? Well, if you ask a 6-year-old that question, they're going to look at you like you got 3 heads. They don't quite know what you mean by foggy. So what we did is we actually took these symptom scales and we administered them to a host of children of all ages and looked at which symptoms were, number 1, understood, and number 2, discriminated them, kids with concussions from kids without concussions. And we came up with the fact that only 5 items were useful in younger kids, 17 items in the 8 to 12, and then 21 items in the 13 to 18. But we also have a parent companion symptom measure as well, where we get the observations of the parent and what they think may be happening with their kids. So again, assesses the 4 symptom categories. I'll show you in a second that we look at both pre and post-injury ratings that are developmentally relevant. We published all the psychometric characteristics of this, and this is a scale that's used widely around the nation and around the world right now. Real important that we tap into each of these areas. There's no such thing as a typical, quote unquote, concussion symptom. Some may occur more frequently than others, like headaches, usually 80+% of the time, but we got to be careful. These injuries can manifest in various ways, and we got to make sure that we are using a full symptom assessment of that. So this is a copy of the PCSI, as we call it, or the Post-Concussion Symptom Inventory that we give to adolescents. Now, it's only the first 12 items. It's a 21-item measure, but what you can see is the categorization. The first set are a number of physical symptoms, and the second set are some emotional symptoms like irritability, sadness, and nervousness. What you'll notice is that the youngster fills out the pre-injury. How much were you like this before the injury, and how much are you like this now? And the reason for that is because these are symptoms or behaviors, whatever you want to call them, that occur naturally as well. And we want to know from the perspective of that youngster and or his parent, to what extent is this kid different than his typical self? And we developed then what's called the RAPID score. So here are the cognitive items: feeling foggy and concentrated, difficulty remembering, getting confused, more slowed, and then the fatigue, sleep issues here. And so the RAPID score is the retrospective adjusted post-injury difference score. Again, retrospective is the pre-injury here. We subtract the post-injury from it, or vice versa. We subtract the pre from the post, and it gives us that RAPID score. So that's our central thing that we look at. And again, for any of you who are working with kids, especially if they've got some challenging backgrounds, you want to take their pre-injury status into account. And basically what we're looking at then is what's the change from their pre-injury to their post-injury. What's the difference there? And we can also look across recovery. And that then begins to give us the symptom types that I'm going to show you are going to become targets for our interventions. This is a, I'm going to actually use one of my drawing tools. I'm going to get fancy on you here. Let me see what color I have. See if I have any cool color. Well, I may not. Okay, so what I want to show you is, let's say that you assess the youngster the first time. This is the first visit. Again, we're gathering the RBL, which is the retrospective baseline. Tell us how you were before the injury. and tell us how you are now. And really, as I said, it's you take the post-injury and you subtract the baseline from it, and you get that rapid score. And I'm going to show you some of the work we've done to validate this kind of a difference here. Then we want to track these kids over time. And again, this is where the trajectory idea comes in. Each time the kid comes in, we ask them, how are you before? How are you now? Third visit, how are you before? How are you now? And that rapid score, if they're making a reasonable recovery, is going down, down, down. And that trajectory line that I showed you is actually based on the work done through that 5P Canadian study, and they used this model. They used our rapid score with the PCSI in identifying that. Now, what you'll notice is that there's a little bit of a drift downward in the ratings from visit 1 to visit 2, from visit 2 to visit 3. That's pretty typical. We call that the rating scale attenuation effect, just what happens when you use rating scales. But it's really important to take that into account, because if you just use the first score and it was even going across, what you would notice is that the rapid score would be different. It would be less of a score. So it's very important here. Now the other thing that we can do, of course, too, is to examine the differences between your rapid score at visit 1 and your rapid score at visit 2. Is there a significant change between that score from time 1 to time 2 and from time 2 to time 3? That gives you an idea of whether the trajectory of recovery is a typical one or not. So I will show you a little bit more about that here in just a sec. What we have here again is a similar kind of thing where you're subtracting the before injury from subtracting the before injury ratings from the current ratings. Here are some of the items that we put into our executive inventory that looks at working memory, that looks at emotional functioning. And what we can do here is, again, our rapid score, we've got data to show us whether there's a significant difference between the pre and the post here. And see, so you have a rapid score of 8, and you see that anything 4 or over exceeds a 90th percent confidence interval, which tells us that that's probably a significant change in their functioning. And you can begin to subtype your functioning there, and then over time. So the idea here, again, is we want to track that recovery. We want to know if you're having challenges with that trajectory over time, and we want to know, is it in the specific areas of physical symptoms like headaches or balance problems, or is it some cognitive difficulties? Is it emotional issues? Are you having particular sleep problems? So we can do that by subtyping. And of course, we know that these injuries affect your academic functioning. One of our postdocs published this paper back in 2014, I believe it was. And it tells us that, this paper told us that, we followed almost 350 kids across the kindergarten to 12th grade. And what we found was that actively symptomatic kids definitely had greater problems in just completing their work, in their symptoms affecting their work, and were in greater need of supports. So again, I mentioned these symptoms here. These become the targets for those supports as we're thinking about helping kids. One of the papers, or it's actually a chapter that I published, was a pathway. What are the things we want to do from the time that the injury is identified at the school, so notified, say, by a parent, my son or daughter was injured, who on a concussion management team then starts to ready things. Is there somebody who's going to monitor their symptom or medical status? Is somebody who's going to kind of help to organize the academic supports? We have a school letter that we've developed that we really advocate for the local pediatricians to be sending to the school, so that the school is aware of what is the symptom burden of that youngster. And then the school can develop a support plan based on that. When the student returns to school, they check in obviously with the symptom monitor, with the academic folks, and a plan is then set out to support them, various kinds of accommodations, and they're monitored periodically to see, is their recovery progressing as it should be? Are they able to do the work or not? Do they need certain modifications in their everyday program? That's the post-concussion return to school letter that the healthcare provider uses, that we really actively recommend. Here's the gradual return to school guide that again helps us to really ease the youngster back into school, and it talks about the amount of time they spend in school, the types of activities and expectations you should have for them during that stage, and then what would be the criteria to move them on to the next level. And so this is just a pragmatic kind of schema here to help you think about how we want youngsters to get back into school. There certainly are a number of kids that should return to school probably on a partial day basis, as they're still recovering from those early, more challenging symptoms, but many kids can go back full day, but really need to have rest breaks built in and other kinds of accommodations that can really help them. We have a way then to say, okay, you're presenting with various kinds of symptoms, and it's playing out in various ways in your school. So, for example, somebody who's having troubles with kind of their working memory or their short-term memory, well, they're having trouble holding instructions in their head and lectures and being able to take notes and read stuff and hang on to it. So what do we need? Well, maybe this is a youngster that needs a little bit of help with some repetition, the teacher or maybe an aide coming up and kind of making sure that they've got the information actively, or maybe they need it written down rather than a verbal instruction. And in some cases, particularly with note taking, maybe the student gets a copy of the teacher's notes here. So these are things that many of you who work in the schools recognize or supports that we use for other kinds of issues with kids. And so this is not necessarily something that's so new, but it's applied now to the challenges that present here with concussion. So we look at the symptoms and we look at how we can then manage them. For example, light noise sensitivity, and you might have somebody wear sunglasses or sit away from the bright sunlight coming in, or maybe limit the exposure to smartboards if that's bothering them, or turn down, the glare factor there. Maybe let them slip in and out of class a little bit, a couple minutes early or a couple minutes later, so they're not in the busy hallway that's overwhelming. Maybe they eat lunch with a couple of friends and not in the busy cafeteria. Sometimes we even have kids wear earplugs, which of course we know doesn't really block out all the sound, but it does tend to dampen it a little bit so they can tolerate that environment better. So the whole idea is identifying that symptom pattern and looking at how you can accommodate it along the way. So the target's there. Another thing that we think about doing, and this is really important, especially for the underactivated kids. So we get kids that come into clinic here, the kid's feeling really sad or really anxious, hasn't been back to school very much, has been told by someone to kind of sit out until their headaches are totally gone. And frankly, that's waiting too long. It starts to put a real burden on top of the youngster. And if they have any ounce of anxiety or mood problem, you just see that really accelerate. And especially with high school kids where the work demands are pretty significant, they get that feeling of everything piling up on them, and they're really overwhelmed when they go back to school. So we really think about what can we do now, what's the critical work that they need to get done, but at the same time, we talk about guiding this progressive activities of controlled exertion. And if you think about progressive activities of controlled exertion, that's the acronym PACE. And so we talk about guiding the pace of your return. Again, most kids that fall into that typical recovery, we can just coach them up, we can reassure them, we can make sure that, again, there's some basic management of the work demands, and they do reasonably well in going back to school. But the PACE program, it doesn't use the word rest. it uses, again, the four-letter word PACE. And the idea is we really want kids to understand what we call the positive foundation for recovery. We educate them about their injury, and we reassure them that they're going to get better, and here's some things you can do to get better. We say, what's your school day like? What's your weekend like? What are your evenings like? So we define the parameters of what they're doing, their activity, and what their symptom response is, or their exertional response. And we teach them how to manage that, how to kind of work in ways that doesn't explode their symptoms, that keeps their symptoms under control. So it's really, we think about it as being sort of a self-efficacy modeling here. Can I feel in control of my recovery? And then we reinforce the heck out of their positive progressive path to recovery. And kids may not even realize, but I was nauseous the first 3 days and not now, or I was dizzy that first week. I really feel much better now. My headaches are still here, but they're not as frequent or not as hard as they were, in those first few days. And so you can really reinforce your brain's doing some work and getting better here. We need to help you continue and kind of keep positive about it. We have to dose your day in ways that doesn't overwhelm you. So, and we get kids active with physical activity. Some real good work now. This is some studies done literally now 10 years ago by Isabelle Gagnon and John Leddy. And what they showed was that it was actually safe to start activating kids, whether it's walking around the block, whether it's doing a little bit of treadmill work, doing something that starts to get the heart rate up a little bit, that delivers important chemicals to the brain, and are very, very useful for recovery. And again, there have been a number of studies that have been published. These are still some of the early ones. We actually give them an exertion rating table and kind of start them out at a 3 or 4, kind of easy, just feeling a strain, and really get them moving. Does wonders for somebody who's feeling depressed or anxious, or who's got sleep problems. And again, it gives them some sense, I'm doing something to help my recovery. It can even help to reduce some of the headaches, and even combat the fatigue that they might feel. So when we look at this, again, it's most kids are going to do reasonably well in their outcomes here. We know there's some, though, that are a challenge. And again, usually what we find is that that's a youngster that has a pre-injury history of whether it's headaches, anxiety or mood problems, some cognitive difficulties like learning disabilities or attention deficit, who may have a challenging family environment that's not well organized. They're having to kind of work hard just to maintain themselves there, or maybe where the school is not understanding and they're really experiencing much higher demands than they can handle. And that's when we start to see kids really start to fail in their recovery. Now, there's always the other side of it too, and it's just, in my experience, far, far less of the case where kids are starting to manipulate their school so that they're getting out of things. And I always hold the independence carrot over their head. Say, you know what? If you got a concussion that's affecting this, then you can't do that. Like go on the school field trip, or do the same thing in recess that you normally do, or attend your PE class, or play in your sports, or do various things. So most kids respond, especially adolescents, they don't like their freedom and their independence being threatened. So I do find it's relatively rare. But again, sometimes we have kids that are so sluggish, so literally out of shape, because they've been kind of undermanaged, that we really need to get those kids activated and give them a much more of a positive outlook toward their recovery. So we know that general health promotion, getting good sleep is important. We actually recommend getting close to 9 hours of sleep. Again, managing the typical stresses, and that can happen either by the youngster advocating for themselves, but certainly also by the environmental demands, school, parents, coaches, whatever, not putting demands on them that they can't meet. Knowing that it's going to take some time for them to ultimately get back to their recovery. And then sometimes we're referring them on to a good therapist to learn some good cognitive behavioral strategies to manage that stress. As I mentioned, good physical activity increases heart rate, increases endorphins, increases brain-derived neurotrophic factor, or BDNF. That all seem to be good for the brain's recovery. Certainly we start to see, again, that perfusion through the body that's helpful. Making sure that they're hydrating and also eating well, very important there, and making sure that they're with their friends, they're doing things socially, even if it's for short periods of time. So all these things are so critical, for kids with these complex injuries, because many times they're actually being over-restricted and not actively managed, and that's a challenge, that's a problem. They'll tend to retreat, and again, then we start to see all the other adverse effects like anxiety and mood problems. So again, in our cases here, the typical cases are ones in which we can reassure, we can do some basic management of their symptoms, using them as targets, and manage around that using our symptom targeted management plan. But it's those atypical kids where the headache, we sometimes have to send them off to a headache specialist, to a behavioral medicine person to kind of manage, again, the pain response. Kids with anxiety, mood problems, clearly, sometimes it's medication, other times, they're responding well to their therapies, psychotherapy, cognitive behavioral treatments. And then again, kids with ADHD and learning disabilities that come, that they have before the injury, that oftentimes is exacerbated. And so now what we're trying to do is build even a greater set of accommodations to manage that, knowing that over time they're going to be relaxed. These kids are going to recover. They won't need quite that degree of management of their attention, or learning needs. And then, of course, as I always find, working with the family as early on as possible to frame the nature of the injury, to make sure that they're not over-responding or under-responding. There's so much in the media now about this injury that it's just overwhelming. And much of it is, the more dramatic cases that quite honestly, we don't know how they apply to the typical kind of recovery or the typical kind of injury. So you hear about chronic traumatic encephalopathy. It's a real thing, but we don't know who it happens to and why it happens to them. And that's the problem there. So we really try to reinforce with families that we're going to do everything we can to help your kids get better. Those kind of downstream problems we're not going to worry about because we don't even know how it applies to your son or daughter's situation here. But again, working with the parents, as we all know, is critically important. So let me stop there and start to take some questions, particularly either about the things I've talked about some challenging cases that you're wondering about. So I will wait for Amanda to take on those questions.
Okay, it looks like we have a question from John Albrecht. Do you get the same kind of data if the patient completes the survey or if the survey is read aloud?
That's a good question. Let me just say that, and by survey, I'm assuming you're meaning the symptom scales. First of all, we actually read the symptom scales to younger kids, certainly the 5 to 7 year olds and the 8-year-olds who may have still a little bit of a reading challenge. We read them aloud. With most adolescents, what we do is we explain the scale to them ahead of time and then have them fill it out. It is not too frequent that we have to read them out aloud, again, unless there is an issue with their reading. And it's possible that you can get a different response. I will tell you that we get probably what you wouldn't imagine, which is sort of the reverse response, where when I talk to a youngster and interview them, and they're saying, yeah, I feel okay. Yeah, I'm okay. I'm not sure. And then they do the questionnaires, the symptom scales. We actually find that they report more on the symptom scales. They start to think about it more. They feel more comfortable or something, or maybe we've kind of got them thinking about it. Whereas when they're initially being asked about it, they haven't thought about it quite as deeply, or maybe they're not sure how to express it. Now, that's not all the time, but sometimes we see that with kids. And I'll go back and I'll say, listen, I just want to check with you because you said that you really didn't have too much of a headache, but you're reporting it to be a lot more. And then they can have an opportunity to explain it.
Thank you, Jerry. Any other questions out there? This is your opportunity to type that into your chat box.
Let me ask Amanda, do we know of the individuals who are on, how many are either teachers or school nurses or school psychologists or therapists of one type or other fields?
Not without cross-checking their original sign-up sheet. I don't have that there. We have Denise Sims, who says that she is a school
nurse. Yep, I see that. Okay, good. I think school nurses are really ideally that point person in the school for this. That can be that liaison with the the medical system, pediatrician, hopefully, and then ideally working with a guidance counselor or someone who can kind of be more of that academic. And then I see Nora as a speech therapist. Okay, good. And John's the high school counselor. Good. Yeah, 6 schools. Oh, I know. School reintegration specialist. Okay, so Peggy, I'm wondering, and I see we have a question here in a second, but I'm wondering, school reintegration specialist, do you work mostly, Peggy, with more complex TBI cases, or you work with all kinds of kids with disabilities? Sarah's a school psychologist. Good to see that. School nurse, Terry. Okay, good. Yeah, so we got a good mixture of folks here. Work with all types of A and TBI. Gotcha, Peggy. Okay. Yeah, well, I'm very impressed with Oregon and the kinds of systems. I know when I've been out before, we all bemoan our own situation. We don't have enough of this, we don't have enough of that. But you guys actually, I think, have some pretty darn good people and services, at least in the school systems that I've seen. Early intervention. Now, there may have been a question, Amanda, that was asked earlier.
Looks like we actually have 2 questions in here. So
yeah,
I'm scrolling back through.
Right.
We've got so from Jennifer, she wants to know, what suggestion would you give for physicians who might want to use something quicker than the ACE for acute assessment?
Quicker than the ACE? What? So we did a study with the ACE, and it took, on average, I think it was 3.5 minutes to do. And because what you do with ACE is you, first of all, just define the injury, which you do anyways. Secondly, you then ask the question, tell me the symptoms, yes or no, whether they're more than they were before. So we have a specific question to basically say, are you experiencing this any more than usual? Headaches, yada, yada, yada. You go down the line there. And then you identify the background of the kid, which a lot of the pediatricians know anyways. There's a kid with chronic headaches. There's a kid who's had 3 injuries before. There's a kid with ADHD. And that's it. That's the ACE. So it's relatively quick to do. The post-concussion symptom inventory is a little bit more involved, only because they've got to make some decisions based on those dimensional ratings of 0 to 6. But and that's, by the way, the parent or kid that does that, not the pediatrician. So we thought we made it reasonably quick for the pediatrician.
Okay. And then from Sarah Magnano, we said, what would you recommend for a pre-injury, post-injury measure when the school team, TBI evaluation team, finds out about the injury months or years later?
Yeah. So, well, first of all, I think finding out about it months or years later, if it's truly a mild TBI and it's years later, there is, whatever you are seeing is not likely, an active factor from the concussion. I can tell you that. And one of the problems we're having these days is that people are now making these attributions. Oh, they changed so much. Well, they may have had a certain event, the injury, but then people start to think differently and act differently and attend differently and do different things. And there becomes this almost secondary snowball effect. what we find in the kids that we see with chronic problems is that they were coming into the problem or into the injury with problems beforehand, and it's only magnifying them now. But then there's this, it was all about the injury, and that's where we just try to clarify. It's really not all about the injury. And I tell families, here's the good news. It's not a brain injury right now. It's something else going on. But again, maybe your son or daughter got stressed or other factors, their headaches accelerated for other kind of ways, and, their sleep has been off. And so a lot of times it can be a snowball effect. So those kinds of kids, there are challenges. The problem with a pre-assessment when you start to get out multiple months to years later is it's very difficult to get an accurate pre-injury assessment. There's going to be an attribution bias. And so I don't have any great way of understanding that. But I do still think that using our typical behavioral inventories, and Sarah, I see you're a school psychologist, if I remember that was it. I would still use, the BASC or the, we developed the brief, obviously, or the CBCL or something to look at sort of their general functioning behaviorally and academically. And then you can talk to them and ask them, how much of this has changed since before. But I would be very careful about that pre-injury assessment when you're talking that far out.
Okay, thank you. And then another question from John. He said, sorry he missed the beginning, but if 70% resolve in 1 to 4 weeks, what is the breakdown for the other 30%? All grouped in 4+ weeks?
Well, the 30% took longer, and the bottom line was, in looking at the trajectories up to 3 months, only about another 10 to 15% had recovered by 3 months. So there was, roughly about 15% of the kids in this Canadian sample that, were still, that at 3 months or greater were still symptomatic. Now, the issue I will tell you here is that this was a natural history study. There was no intervention put in place or anything along the way. So what we don't know, I wouldn't say that we would look at that and say, well, we know that 15% are always going to take 3 months or longer. If you're doing good evaluations and you're targeting, again, where that problem is at 4 weeks, you should be putting an active intervention in place. And I would argue that a reasonable percent of those kids are going to be recovered by 3 months. So that's not a study that was not part of the study.
Okay, thank you, Jerry. Well, I think we are a little past our time.
Okay.
But that was really wonderful. Thank you so much for taking time to answer all of these questions. And thank you to everybody who took the time to participate. It always makes these webinars so valuable. I'm going to go ahead and end the recording.